Good morning, everyone. I'm going to be talking about the final diagnosis aspect of this presentation. To begin, I'm going to be starting to talk about the importance of newborn testing with respect to SCID. The reason that this test is so important is that SCID is very, very difficult to detect, and most newborn cases are going to begin asymptomatic, and until the telltale signs of recurrent infection, whether it's ear infections or throat infections, and failure to thrive being the number one most common first sign, it is very hard to detect. It's also important to detect for SCID because this is acquired hereditarily, so finding out where it came from and who it's going to affect later on is also very important. I'm going to be talking about two types of SCID: atypical SCID, known as leaky SCID, versus typical SCID, or SCID. In typical SCID, we're going to have the autologous T cells, which are going to be found less than 300, with a T cell proliferation rate less than 10% of the healthy normal population. With typical SCID, we're going to have maternal engraftment. And what maternal engraftment means is that the baby is going to have T cells that belong to the mother. In leaky SCID, we're not going to have maternal engraftment. Therefore, the baby will not show any T cells that belong to the mother. In leaky SCID, we do have a reduced number of CD3 T cells, but the major difference between leaky SCID and typical SCID is that in typical SCID, we have very, very low numbers of T cells because there's no proliferation happening, or proliferations occurring below 10%. With leaky SCID, we have proliferation occurring at 10 to almost 50% of a normal healthy population. So incomplete and hypomorphic gene mutations could be a resulting causation of leaky SCID. And once again, maternal engraftment is not going to be present. So less than 30% of the lower limit of T cell function as measured by the response to PHA is seen with leaky SCID, otherwise known as Omen syndrome or reticular dysgenesis. Next, I'm going to be showing you a graph that's going to be comparing SCID versus leaky SCID and gene defects associated with both disease states. We have two main discussion points: T negative B positive SCID versus T negative B negative SCID. In T negative B positive SCID, one of the major gene defects that I've isolated here in the red, as you can see, is IL-7RA. And if you recall, what we know about IL-7 is it's important because its association with IL-2 is known to increase T cell proliferation. If you look at, on the other hand, T negative B negative SCID, we show a gene defect to ADA. And if you recall to Dr. Sahu's lectures, in immunology, we do know that an ADA gene defect is related to SCID because we don't have any proliferation of B or T cells, hence the name T negative, B negative SCID. How is SCID diagnosed? A blood sample is usually taken of the newborn. It's usually a heel prick test, and what it's checked for are TRECs, and what TRECs are T cell receptor excision circles. Now, if we see low levels of TRECs, this is not a confirmatory test because this can be due to various things such as other immune disorders unrelated to SCID, prematurity, and the reason that, and since this is not a non-confirmatory test, a full CBC as well as flow cytometry is required to confirm SCID. Thank you very much.